This is a quick review on managing bacteria or urinary tract infections, also called UTIs, and how to manage them in pregnancy. So we have a priority here to reduce preterm birth because there's a bit higher risk of preterm birth here in Nunavik. And one of the things is that UTIs are associated with preterm birth in pregnancy. And so screening for them and treating them is shown to improve outcomes for newborns. So what we do is we test women who are asymptomatic. So these are women who don't have symptoms, and we offer a routine test in the first trimester. And there we're trying to rule out asymptomatic UTI. We also offer, for women who have had a history of preterm birth or birth before 37 weeks, we offer routine testing of urine in the second and third trimester. As well, women who have had a UTI recently or have recurrent UTIs, we offer monthly testing. So each time she comes in at the beginning of the pregnancy and later on, just once a month, we have her test her urine. We send it to the lab for a culture and to see if anything grows, so any bacteria that would be present in her bladder. Also, if women present in the clinic and saying, I have symptoms of a UTI, by all means, offer them a test. And that's the symptoms are increased frequency to pee, burning when peeing, or if they have pain just above their pubic bone. We also do a urine culture when the woman's complaining of contractions, so we're worried she may have preterm labor, because preterm labor and a urinary tract infection can sometimes look the same. So there's pain just above the pubic bone. It could be the contractions. It could be a urinary tract infection. So we'll do tests to rule out that it's contractions that's causing the cervix to open in preterm birth. And we'll also do a urine culture, to make sure she doesn't have a urinary tract infection that's mimicking the symptoms of preterm labor. So to do the test, you explain to the woman that she spreads her labia with her fingers in the bathroom and she cleans her vulva with the purple cleaning cloth. And then she pees a little bit and then pees into the bottle, so into the blue pot, so that she can get a clean catch. So this is so that the normal bacteria from the vulva don't contaminate the test. There's no point doing a urine dipstick with it's also called a bayonet, to test for leukocytes and nitrates. It's different if you're in the field. If you're not close to a lab, maybe you want to use it, but it's not very accurate, and we can just send the urine culture to the lab instead. If she has serious symptoms, by all means start treating her and wait for the results. You can also call the lab and get a preliminary result in 24 hours, but usually the final result comes in 48 hours. The code for OmniLab is U, and the site is UPD, or Urine Priest Direct. Okay, so here we have just kind of a summary. So we're either going to do a routine test for women with no risk factors, or we'll do a routine test in the first, second, and third trimester if she has risk factors of preterm labor, preterm birth. Also, if women come with signs and symptoms of a UTI, by all means test. So we're going to order a urine culture, and if the results are what we see is over or equal to 10 to the 8th, so it's like over, not quite a billion, but it's over 1 million things were growing in the liter of, estimation of the liter of pee. And then the lab does an antibiogram. So in English, it's called a culture on sensitivity. In French, it's called an antibiogram. But even when we're speaking English in Nunavik, we use antibiogram. It's just kind of stuck. So what the lab has done is they've grown the bacteria, and then they tested each of the different antibiotics in one corner of the plate to see which one prevented the bacteria from growing. So I'll show you a result in a second. So after you treat the woman with the antibiotic, you're going to control or retest in 1 week after the completion of her treatment. And if it's negative, so if the antibiotic worked, then we're going to repeat and do a urine culture every month for the rest of the pregnancy, because she's had a urinary tract infection. If it's still positive, so if the treatment wasn't successful, We can treat according to the antibiogram again. We should also talk to the doctor too, because there's some women who just struggle with repeated urinary tract infections, and they may consider, a discussion with the doctor about taking antibiotics throughout the whole pregnancy every day. They also may talk about taking antibiotics after sex. Each time they have sex, they take antibiotics to prevent infection. So those are options, and we can discuss that with the doctor on the team. So this is what an antibiogram looks like, or a culture and sensitivity. So the lab gives us a report. So they say that the sample is from urine. The site is urine pre-direct, but it's not written here. And then the analyze that was demanded was, or asked for, was a culture and sensitivity, or antibiogram. So that's the thing where the lab has grown the bacteria in the pee. And then we use the different samples of antibiotics to find out which one is the best one to use. In this case, the woman had E. coli, or Escherichia, I don't know how to say it, coli, and it came back with 10 to the 8th, so greater than or equal to 10 to the 8th, and so that means we should treat her. So I'm going to look down this list of antibiotics and see which one the bacteria is sensitive to. If it's an R, you don't want to treat with that one because it means the bacteria is resistant to that particular kind of antibiotic. So in this case, ampicillin, the E. coli bacteria is resistant to ampicillin, so it won't kill it. But amoxiclav, it is sensitive, and that could be one of your options. Nitrofurantoin, or it's also called macrobid, is sensitive, as well as fosfomycin. So this is the medication guide by the OSFQ, or the Ordre des Sages-Femmes de Québec. And we do things a little bit differently than what they've laid out here, but I'll just explain it. So in the first trimester, we're going to screen the woman, and if she's positive, they say greater than or equal to 5. But we have a higher threshold, so we want to see a lot more bacteria than just 10 to the 5. Because that's according to Memo Perinatalité, which is what the doctors and the midwives use here in Nunavik. So let's say she's positive. We're going to initiate treatment according to the antibiogram. The first choice the OSFQ lists is cefadroxil. So in our lab here in Kuujjuaq, cefadroxil isn't one of the ones that's used in our antibiogram. So going back here, there's no cefadroxil. I spoke to the infectolog. He said it's not important to add it. So we just go to the second and third choice, as well as using the fosfomycin. So if I'm going to treat according to the antibiogram, I would go for the fosfomycin for the majority of women. I myself would treat myself with fosfomycin because you only have to take one single dose and then a week later retest. If it's still positive, by all means, try a different antibiotic, but you haven't really lost any time by starting with the fosfomycin. And lots of times it works, and if so, that's great. It can be used throughout the whole pregnancy for second and third trimester, so there's no limitations on when you can use it. If you're going to look at the second and third choice, then in the terms of the macrobid, you don't want to use it when she's getting close to her due date. And in terms of this one, the TMP SMX, you don't want to use it in the first trimester or close to her due date. So these two have limitations on when you can use them. The other one is the amoxiclav. It's a common one, and it's only taken twice a day. Amoxicillin is 3 times a day for 7 days. Not great. And Cefixim is just once a day for 7 days. So in this case, go for the fosfomycin first if the antibiogram says that the bacteria that this woman has is sensitive to fosfomycin, and then reevaluate later if needed. The other thing that's a bit different is they say whether she's first trimester, you're just doing routine screening, or if there's symptoms, there's different thresholds. For us, it's just always the threshold is 10 greater than or equal to 10 to the 8th. So we don't have varying thresholds. Also here, that's different. It says, if it's negative, consider doing a third trimester screening based on clinical indications. So if it's a history of preterm birth, we do it actually in the second and third trimester. finally, over here, we're going to redo the culture 7 days after the end of treatment. So here they just gave a range, which is fine. But in the event that, this is a good point, in the event of multi-resistant bacteria, so let's go back here. In the event that like all of these are R, by all means, we're going to do a medical consult because we have to have the lab retest the urine and look for a different type of antibiotic that'll work for this woman.